Hello, everyone. Thank you very much for having me here. I did my residency here what feels like an eternity ago when the new building was not built. But this is the same room, so this feels a little bit like home. So I'm glad to be back, and I will be talking to you today about EEG in cardiac surgery. Initially, I had designed a talk, or I imagined a talk to my colleagues in anesthesiology when I discovered that this was a broader group of cardiologists, cardiac surgeons, et cetera, et cetera. I decided to talk about EEG as a more broad topic in this area of medicine. So I hope that this will please everyone to some degree, and that you have things that you can see in this talk that resemble elements of your practice. And if you have questions that go outside of the scope of this, please ask them, and I will answer any of those questions. You can contact with me at any time using this information. You'll also see links to certain references in my talk with QR codes. So at any point, you can just scan a QR code and access those resources. This is where I work. It looks substantially the same now as it did in 1950 something when this picture was taken. But a lot of the early history I'll introduce in this talk was around this era in the 1950s when EEG was in its heyday. And a lot of that interesting research was done in American centers, but some of it was done also in Canada, much of it in Montreal. So I will basically reintroduce, because you all learned about EEG to a degree, so I will reintroduce the EEG to a diverse audience with hopefully some elements that are of interest to many people. I'll talk about the history of EEG in cardiac anesthesia and in cardiac surgery. And then I'll outline maybe the role of EEG in predicting perioperative adverse outcomes in cardiac surgical patients today. So really quickly, EEG is a bit like an EKG in the sense that we place electrodes all over the head. If you want to be thorough, you'll place electrodes in all of these points that you see listed in the standard 10-20 montage. For convenience in cardiac anesthesia, we very often will put them only in the front just because we have a piece of scalp that doesn't have hair and is available to you, whereas the back is kind of sitting against the surgical table. And for simple convenience, we often will omit essentially all of these. When we do things a bit more seriously in the OR, we will put often front half. Again, largely because the stuff we care about in the brain, motor function, sensory function, is housed in this part of the brain more so than that back here where useless things like vision and that sort of thing are housed. But regardless, we put electrodes on and we attach them to a differential amplifier, and we are able to get a nice clean amplified signal from something that is very small. We use a differential amplifier because the noise, electrical noise, especially in the operating room, is so abundant that we need to basically remove this. So by comparing inputs to this, I guess, this pictographic amplifier, we can remove these noise sources and get a clean signal out. That will become more relevant in a second. What are we measuring? Well, unfortunately, the EEG is measuring only the cortex. And the reason for that is because it happens to be that in the cortex, all of the pyramidal neurons are arranged in this perfectly linear fashion. And so when you get volleys of electrical information, they can be summed spatially because all the little wires are parallel. Whereas in the rest of the brain, all the wires are kind of crossed in a funny way. And so electrical activity all nulls out electrically and you can't measure much. And so it is the summated postsynaptic potentials that give us EEG. EKG is not really different in the sense that you have myocytes, but myocytes are also not random. They're also kind of linear. They're in muscles, so they're necessarily striated, and they can also volley together. They do volley together to give you larger signals that can be measured all over the chest and the body, of course. So this is what you get out. You get an EEG that looks maybe like this in an awake person with their eyes closed. By convention, it's very hard for me to even reach. By convention, we have these names that are the comparison of two electrodes. They correspond to the symbols that we see here. And they're arranged usually in a stereotyped fashion for us to read conveniently. I'm not going to go into that because it's not important. What is important, though, is this little standard marker. Here, 1 centimeter, 1 centimeter represents 100 microvolts. So maybe these here are 100 microvolts peak to peak. If you kind of think about your EKG, everyone remembers this, standard marker, right? This is full standard. So that is to say that 1 centimeter or 10 millimeters corresponds to 1 millivolt. So we're already talking, by comparison, EKG and EEG, we're talking about 1,000-fold difference in amplitude. The EEG is a very, very faint signal, very, very susceptible to electrical noise. And so we, in considering the signal to noise ratio, where, for example, your EKG might be let's say in a big one, 35 millivolts peak to peak. So if your noise is a significant fraction of that, you're dealing with a picture kind of like this signal to noise ratio, where the signal to noise ratio is 100, 40 decibels of signal to noise ratio gives you a nice crystal clear image. We're dealing in EEG land more often something like this, or maybe like this at the worst case. So there isn't a large degree of visual interpretation, because of course you all see that this is the same picture. The human brain is wonderful at excluding noise, but machines are bad at excluding noise. So there's still a huge element of human interpretation in EEG for the reason of bad signal to noise ratio. By convention, I'll just introduce this quickly. By convention, we divide the EEG into frequency bands. And we do this just for convenient parlance, where we kind of arbitrarily say that high frequencies, 12 to 30 hertz, are in the beta range. Delta range would be arbitrarily more than 0 to about 4 hertz, and then the alpha range is 8 to 12 hertz. Theta, there's some disagreement over what these numbers should be, but it's essentially between alpha and delta. So you'll hear me use the word delta and alpha a lot in this talk, and I'm referring to these frequency bands. You get other things that are higher than this, and you get infra-slow, which is much lower, but those are generally rarely relevant to clinical medicine. All right, so why do we like EKG and EEG? They're the same. They're cheap, they're reproducible, it's portable, you can move a device easily, it's dynamic. If you look long enough, if you strap in a Holter, you get a long notion of someone's cardiac rhythm. If you put an EEG on for 7 days, when you can capture multiple seizures, you can see sleep-wake cycles, you can see all sorts of interesting things, so it's dynamic. It's non-invasive. Okay, maybe you could debate whether pulling hair off with stickers is invasive, but it's non-invasive. We agree on that. It reflects cellular and tissue function, ischemia, channel dysfunction. Both of those things can be identified both in EEG and EKG. And it has some degree of localizing value. It's not perfect. You're not looking at a structure, but if you put an electrode here and you see spikes here and you don't see them elsewhere, well, then we can conclude that their spikes are generated in this region. In the same way, if you see ischemia, 2, 3, and AVF with reciprocal changes, that makes sense, then you can localize roughly within the EKG as well. Never quite as well as seeing it with your eye or seeing it perhaps with ultrasound, but you can localize relatively well. In contrast, however, EEG does not have robust signal to noise ratio. We've discussed already. It doesn't have structural specificity. If you see, for example, a prolonged QRS, you can kind of confidently state that the abnormality would be within the his Purkinje or distally, right? You can have cardiac anatomic boundaries for the things you see. In EEG world, you can't really say this because the EEG is only generated by the cortex. So you can have abnormalities in the EEG that are actually driven by an abnormality in the brainstem, but you can't say that confidently. You can only infer that based on other clinical parameters that lead you to believe that there's brainstem dysfunction. So it's a little bit indirect that way. We don't have quick electrode application. You can't just go boom, 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 and you're done. You kind of need to prepare things. You need to measure craniometrics so that my FP1 is your FP1, and my distance between FP1 and F7 is the same proportional difference for me and for you based on the size of my head. So it's a lot more time-consuming and kind of picky to get good electrode placements. And the ease of interpretation, I don't mean to be insulting, but the ease of interpretation is considerably more difficult for EEG, and the barrier to entry is considerably more difficult. If you could imagine that this is the book for experts, this is the book for everyone, well, obviously this is not good enough for cardiologists, but it does give, as much as I'm loath to admit, it probably does give a reasonable understanding of some elements to everyone, to the medical school masses. Everyone knows Salvador Dali, the picture of the digoxin, no one? I'm the wrong audience, obviously, for this. People know this book better, but there is something to be said for vulgarization of EKGs. In EEG, we don't really have this. There's no easy way to interpret EEGs with fidelity, and the inter-rater disagreement amongst amateurs is very high. So they're different tools. So with that in mind, let's pivot a little bit, and we're going to talk about history, back to the history books. And so we'll talk about the history of EEG and cardiac anesthesia, specifically through the lens of anesthetic adequacy monitoring, through safety, and 111. Love that. There's a change from my presentation. Anyway, 1, 2, 3, outcome prediction and personalized medicine. And so these things were sort of discovered as time went on in cardiac surgery, viewed through the lens of EEG. So back in the 1950s, so EEG was invented in the late 20s, like 1929, Hans Berger. So already by the 1950s, people are using EEG to kind of look at stuff because there were not that many tools back then. We didn't have pulse oximetry, we didn't have agent gas monitoring, we didn't have blood gas monitoring because we didn't have cheap tools. Those things were all time-consuming tests you would do in labs, maybe one sample at a time. You couldn't have anything continuously. So EEG was a continuous tool. So people were very excited about this. So this group here, Faulkner and his friends, basically said, okay, well, let's take patients under anesthesia with an intravenous barbiturate and see what we can glean about their EEG at different clinical stages. Because at the time, anesthetic was given by clinical metrics. It still is to a degree, but really it was based on the respiratory rate, based on immobility, based on pupillary signs and oculomotor signs. It was very much an empiric art at the bedside. And so he says here, essentially the need for a guide is high because in comparison to ether anesthetics where you had lots of respiratory information, when you give intravenous drugs, the patient just loses all of their respiratory drive, and especially if you paralyze them, then all your clinical signs are gone and you have nothing. So they really needed something, and so they were desperate to find the role of EEG in giving them a monitor. And so they were able to crudely categorize anesthesia into different stages correlated to what we already knew about staging of anesthesia. So they said, okay, well, this is the awake EEG. Then if you give just a little bit of drug, you get this kind of higher frequency beta activity. If you give a bit more, then you get some admixed delta and theta. But if you start to get more, then you get periods of suppression until eventually, if you really pooch it, you have an isoelectric EEG for a long, long time. And so they basically figured this out. They said, hey, it's possible to get in any of these things in some state of anesthesia. And so the interesting thing was all of these are acceptable states of anesthesia, but clearly there was a neurophysiological difference between all of them. They kind of arbitrarily divided them into 5 stages, but it need not necessarily look that way. In fact, these days we would collapse these down into degrees of burst suppression, and we would lump this into it as high-grade burst suppression. So we would have 3 grades now, but regardless, they knew that there was a difference. And interestingly, they sort of come up with this, I think it's a fairly big statement. They say, although it's not claimed that in 100% of cases, EEG changes alone can tell whether a patient will tolerate an incision, whatever. The interpretation of these changes as an index of anesthetic depth has proved of greater value than any single sign we have observed. So this is 1950s, they're already saying, hey, you know what, EEG is probably something we should be using. It's better than our clinical judgment. It's kind of big for a doctor to be like, hey, here's a machine that's better than me at predicting these things. So if you sort of fast forward just a few years, we're now in 1956, I believe it was. This group is looking at the EEG now. They've applied it already in their practice in cardiac surgery, and they're going to say, well, can we use this to find changes associated with going on pump? And I love this. This is the first paragraph of the paper. They say, the electroencephalogram has been continuously monitored throughout the operation in all patients undergoing intracardiac operations with the aid of cardiac bypass in Mayo Clinic. So at this point, it's a standard monitor for them, which is crazy because in fact, these days, it's not a standard monitor. There's no guideline in the world at the moment that actually requires that you use the EEG. But at the time, they had already appreciated the value of it and they were using it as a standard monitor. And if I remind you, this would have been their only continuous monitor aside from the electrocardiogram. So they have 2 electrical indices of the patient's safety. They have some, they can, of course, get the same vital signs we can now with blood pressure and heart rate and all that stuff, but they don't have any other monitor. And so they say, well, this is indispensable to us. They used it for anesthetic adequacy, for depth of anesthesia, but then they also found in this paper, and I'll show you, that it provides some additional information related to patient safety on pump. And so I'll show you some examples. So basically, this is a patient who is under anesthesia already. They put the SVC cannula in, and in the midst of kind of compressing and placing stuff, they significantly decreased venous return, and almost immediately the EEG starts to become slow. And as soon as the cannula is successfully placed and everything, and that flow is sort of reinstituted, the EEG normalizes back to its anesthetized baseline. And they saw this over and over and over and over again, and they published that essentially 70 to 80% of their patients going on pump have this exact change when they're sort of farting around with the SVC cannula, which at the time I'm sure were rigid and poorly sized and didn't have a wide range of sizes. And so there was an element of size mismatch. So they describe also that in children, of course, where the sizes were more limited, but a larger diversity of vessel sizes existed, there were times where the patient would have just obstruction of the venous return by the cannula entirely, and this change would never go away, and so they'd have to pull out and find something smaller and make something bespoke, or, it was very sketchy back then. This change was, of course, known already. We knew from studies of carotid cross-clamping and from studies in dogs where they had made the dogs anoxic or severely hypotensive, that if you do that, you get this characteristic featureless delta frequency slow wave activity, which is usually reversible if it doesn't go for long enough. But if you keep this on forever, then that never comes back and you have done some permanent damage. Similarly, here's a patient who's anesthetized with an acceptable blood pressure at the time. Here they describe the blood pressure as low. This is normal, this is low. They see the slow wave activity, they give a small dose of Levophed, and then the blood pressure comes back to normal, overshoots a little bit, but regardless, the EEG normalizes. So they sort of see that, hey, here's a patient who we would be satisfied with this, or we don't know if we'd be satisfied, but certainly the transition from this state to this state was associated with an abnormal and unacceptably so change in the EEG, which is corrected by administration of a vasoactive agent. So the observation for them here is, well, hey, this is largely indistinguishable from this, but we didn't have any way of knowing that. Like most of us would say, okay, well, that's not really a good blood pressure. That's probably not going to support adequate perfusion of the brain. But clearly at the level of the EEG anyway, the cortical neurons are just as happy at 130 as they are at 70 or 75. So they were impressed by the fact that the EEG was able to show them things that they could not know otherwise, or confirm that bad things are truly bad and reversible, which is nice. Similarly, here's a patient who was on bypass under anesthesia, looking quite nice. To come off bypass, the blood pressure is unsupportably low. It's failing, actually. They go isoelectric, and so they say, never mind, crash back on pump. They go back on bypass, and everything comes back to normal. And so again, I mean, you can usually tell on cardiovascular grounds that somebody has failed coming off bypass. But if you need supportive evidence that their brain is not receiving adequate perfusion, well, then the EEG can do that for you, and nothing else could have done that for you at the time. So this is exciting. You can imagine this paper was extremely exciting. It was cited several hundred times, which for a paper in the 1950s is quite impressive. The list goes on and on in their paper of abnormalities that they viewed under certain circumstances, all related to misadventures, disconnections of stuff, oxygenator fails, things get cross-clamped and people forget to uncross-clamp them. They go on pump, but the solution is cold and they're perfusing the brain with cold saline before you get any blood that has come back. RAP was not a thing. Nobody was priming with warm blood. This is like a different time, right? This is repeated by a different group that finds more or less the same thing. And of course, for my anesthetic colleagues, it's worthwhile to mention that at the time, they were not really using anesthesia as we know it, right? They were using opioid-heavy, very, very, very heavy opioid infusions with a very small amount of volatile anesthesia. So it's really like, they used to call this sort of neuroleptic analgesia, or perhaps you could call it analgosedation, but it really was not anesthesia in the same way. So the baseline EEG was rarely slow. It was more often dominated by fast activity. So these changes were more obvious then than they would be now, which is a little bit of a limitation in extrapolating 1950s data. But the point is that the EEG showed them interesting and useful information. This is an example where you had basically compression of the heart, physical compression during manipulation that was associated with a large degree of slow wave activity. And when they stopped physically manipulating the heart, this comes back to relatively normal EEG. The analogy now probably would be twisting the heart when they're off pump, for example. You can see the manifestations on the blood pressure, but you had no grounds to say, hey, stop doing that. So this was a powerful tool for them to be able to direct surgical gestures. Here's a 77-year-old guy with a congenital IS. I'm not sure of what type exactly, but he had a valvotomy. He's got inadequate anesthetic here. They begin antegrade perfusion here with what they describe as the cool contents of the catheter being mainly saline. And several minutes later, he comes back to this baseline normal pattern. And this is a finding that they found over and over again. And they actually addressed and described in the paper that they addressed this by warming that segment of saline in the aortic cannula. 15-year-old kid with an AV canal defect. Here he has an adequate anesthetic. They insert the caval cannulae. They go on antegrade perfusion here, but the blood pressure at that time is relatively low. They start to get slave activity. They improve the parameters, and then everything starts to normalize. So they really were using this to be more precise about their conduct. So what you can see essentially from this is that the EEG has a role in enhancing patient safety at that time. They used it initially because they felt it was of value to give adequate anesthesia, but eventually they saw quite quickly actually that it probably has a role in enhancing patient safety. So if we pivot once again and look a little bit into prediction, this is tea leaf reading. Does anyone have a grandmother that does this? Look in tea leaves? No. My grandmother used to do this all the time, and I thought it was such nonsense, but I like the picture. So yeah, well, let's talk about using EEG to predict postoperative cognitive dysfunction. Using the EEG from mostly intraoperative, but to some degree from the preoperative period as well. So this is fun. It's fun to look back in history. So back in the 1950s, people already knew right away that patients who had cardiac surgery didn't do well cognitively for a little while or a long while afterwards. And so the people who interested themselves most in this were the psychiatrists. Nobody in medicine, in anesthesia or in cardiac surgery was very interested in addressing these things. So they called in the psychiatrists to deal with all that brain stuff after. And so this group, Egerton and Kay, had consumed 2 other papers that said, hey, we have this incidence of delirium. And they're like, well, that's weird. In our unit, it seems like everyone has delirium. And so their opening paragraphs are like, we have a staggeringly high incidence in our unit. We're going to look at this prospectively. So they looked at all the patients at their institution prospectively for 10 months, which is 141 patients. Things have changed a little. 14 patients per month is a pretty small operation, but nonetheless, this is a 1-year audit, right? They found 90 adults and 51 children. Of these 90 adults, these are on bypass, by the way. These are 90 adults who went on bypass. Only 60 actually survived that. So the mortality was high. And in those 60 patients, 25 of them, 42% of them had delirium. The average duration was 3 days. The average age was 45. So these are young patients. Everyone is having delirium, right? Like pretty much. They also go on to describe post-op psychosis and other sort of neuroses that have evolved afterwards, but they quite clearly define delirium the way we would. It's very, very high. So the question of delirium as an important topic after cardiac surgery was already discovered and identified in the 1950s. And it went on that way where it was a bit of a passing fascination. People reported over time that the delirium incidence was decreasing, but we kind of didn't really no one thought to say, well, can the EEG have something to say about this? I mean, could we predict this some other way, but on clinical grounds? And so the EEG fell out of favor over time, mainly because we got better and better at giving anesthetics. We got other monitors. We got saturation probes. We were able to sample gases and be able to tell, well, I'm giving this much anesthetic, and we know that this much anesthetic is associated with unconsciousness in most patients. And so the EEG kind of fell away as a useless tool and all but disappeared from anesthetic practice until this device was launched. This is the BIS. It was put on the market in 1994. And it basically takes EEG data in and spits out a value between 0 and 100. 0 is this object, and 100 is you all and me, ideally, awake patients. And somewhere in between, you would have an anesthetized patient. And it was just an absolute success, this thing. It was sold everywhere for the reason that people wanted a way to prevent awareness. Why? Because there was a rise in the notion of patient safety in the late 90s and early 2000s. And this felt like a way that we could prevent a really terrible complication of anesthesia. So EEG had its revival with this device for the specific reason of preventing awareness. However, even at that time, people were saying, well, okay, we have this tool. Let's look at other associations. So just to remind you, the value here, a BIS value that's high is an awake patient. A BIS value that's low, crudely, again, we can debate this endlessly amongst ourselves, but crudely, an EEG value that's low is a sign of anesthetic overdose. So this fellow, Dan Sessler, this I think is the most published anesthesiologist who has not a fraud. It could be, I think. He's at the Cleveland Clinic. He's a director of the Outcomes Research Institute and has his name on really hundreds of papers many of which are very impactful and important papers, and I think most of them are true, in contrast to many anesthesiologists who have gained fame for being on hundreds of papers. And so what he found in this study was that if you had this triple low, which is to say low blood pressure intraoperatively, low index on the BIS, so you appear to be over anesthetized, and a low minimum alveolar concentration of volatile anesthetic, meaning we're not giving you an overdose of drug. We're giving you a small amount of drug, but the EEG suggested you're getting a tremendous amount of drug and you have a low blood pressure. Well, then these patients essentially die significantly more often and have a longer hospital length of stay. And so it's not just the presence of that triple low. So here, this is this triple low, low MAP, low BIS, low MAC, relative risk of mortality. This is the mortality risk. It's not just the presence of that thing, it's also the duration. How long do you go on like that? And so the longer you go on like that, the dose of that triple low has its own independent prediction for mortality. And so this is the first paper that really suggests that maybe there's something in the BIS or something in the EEG really that could lead us to identify patients that are at high risk for perioperative adverse cognitive outcomes and death. And so this was looked into, and of course the driver of low BIS is actually generally burst suppression, the state that I mentioned before, where you have some activity, a flat line, and then this bursts of activity that oscillate back and forth. And so this is essentially a prospective audit of 81 patients with high density EEG. They found delirium in 32% of these patients using the CAM ICU. And they found that the longer the duration of the burst suppression, the higher the incidence of delirium, and the greater the severity, meaning to say, if you have a burst and then a flat line and a burst and a flat line, the more time you spend in that flat line segment, the higher your incidence of delirium as well. So this is the receiver operator curve. Burst suppression duration is this black line at the edge. And so this is now we're talking 2014, 2015. So actually it took really almost 60 years, 50 to 60 years before anyone really interested themselves once again in the EEG and whether it could provide us some insights about postoperative cognitive dysfunction. So you've been to Montreal, everyone's been to Montreal. There's like 10 million of these signs. So I'm gonna take a small detour for a second and just introduce a way of looking at the EEG so that I can show you some other stuff, because without this kind of technological point, it becomes very hard to consume some of the research in anesthesia. So if I give you an EEG like this, well, that's fine. This is 14 seconds or so of EEG. That's quite fine. And the way we look at these in clinical practice is we scroll through and we scroll and we scroll and we scroll to look at EEG morphology. But if I wanted to give you an entire night's EEG to look at the sleep architecture, that would be a very inconvenient way to do it. You'd be marking things and measuring intervals would be awful. So if we could look at this instead over a larger period of time and in the frequency domain, it would be much more useful. So for example, if I could give you an entire night's sleep, 6-8 hours of sleep, where I could say, okay, here is the EEG composition at this time and this time and this time, that's a much more convenient thing. So this is called a density spectral array or a spectrogram. And it shows us frequency on this axis and time on this axis. And each vertical stripe here is a piece of EEG that has been transformed in this way. And I'll explain how that works. So Fourier's theorem basically says that a function in the frequency domain can undergo some transformation to be represented as a function in the time domain. So if you took some function like f, which is really a square wave, you can imagine that it's composed of these underlying sinusoids, cosines and sines, of varying amplitudes and increasing frequency. And in fact, if you break it down, you can stratify this original signal by those sines and cosines of decreasing amplitude and increasing frequency. So it gives us two views of the exact same function. This is the frequency domain interpretation, and this is the time domain interpretation. And so you can see that with each successive sinusoid that you add some clarity onto this. So if we start with just the fundamental frequency here at around 1 hertz, I mean, we can look at the square wave, right? The frequency of the square wave from, let's say, peak to peak is around 1 hertz, right? So the fundamental frequency, unsurprisingly, is 1 hertz, but to get all those edge frequencies, you need higher and higher and higher frequencies. The point here is just that you can represent the exact same function in red here in the time domain or in the frequency domain. Those two things are identical. If you imagine the EEG is composed of multiple frequencies, here's some raw EEG, you can kind of mathematically pull this from a slow wave marching through plus this faster thing over top. So this is essentially this plus this. And so if you do this Fourier transformation, you get one of these spectra where you have a peak in the slow wave region and a peak in this alpha band region corresponding to these two frequency elements. Oh, there we go. If you put color on this to denote the amplitude here, so that the low amplitude is blue-green and the high amplitude is red, then you can populate a single vertical line in this longer graph where the peaks at low frequencies and high frequencies correspond to these colors here. So essentially here we have time in this axis where we're looking at samples over many, maybe hours or days. And here we have frequency on the y-axis and we have color denoting the amplitude. Does that make sense? Make sense? Okay. So that, this is the only slide like this. Essentially, one piece of EEG can be transformed into one vertical slice through this longer map of frequency information. And it gives us a very, very useful tool for two reasons. One, with a spot shot view of this, I can tell you that this is what the EEG looks like. And with a horizontal view, I can say it's looked like that for a long time, and it is still looking that way. So with that piece of that tool in mind, which is important, we can start to look at some of the contemporary research in this area. So this is my mentor in fellowship. He's now the department head of an anesthesia department of 300 individuals at the Massachusetts General Hospital. It's an enormous, enormous operation. Great guy. So when he was a research fellow, he was looking at EEG dynamics during general anesthesia and looking at whether or not you could predict burst suppression in cardiac bypass. Because if the observation was that badness is associated with high incidence of burst suppression and longer episodes of burst suppression, the notion was, can you distinguish the groups of patients that get this versus those that don't? And the idea is that a neurophysiological distinction would strongly suggest that patients that exhibit burst suppression have some sort of unique predisposition or actual biological predisposition that should be manifest in their EEG before they have burst suppression. It's a great idea, actually. And so he took these patients and stratified them by those who had burst suppression and those who did not. And he looked at their spectra. And so the groups that had burst suppression has a significantly lower amplitude in this region here. So they have lots of slow wave activity, but the alpha frequency is considerably lower. Viewed a different way, here we have frequency and this is power. The group that had burst suppression is this group here, where the alpha component between, let's say, 12, and you go actually up into the beta range, is significantly lower than the group that did not have burst suppression. And so he says, okay, the absence of alpha or a low alpha amplitude is a marker of a predisposition to burst suppression under anesthesia. And that same group goes on to say, well, is this just a covariate, a statistical covariate, or does it actually produce, does burst suppression actually produce badness? And using a methodology which is well beyond the scope of this talk, they basically say that burst suppression is not just an associated finding, it's actually a mediator of delirium in cardiac surgical patients. So in other words, these other statistical variables, in the absence of burst suppression, do not predict themselves burst suppression, which is quite surprising, right? Poor preoperative physical functioning alone is not sufficient to produce delirium in everyone. In a large group of patients with some confidence, you require the presence of burst suppression to affect that outcome. Just it was quite a remarkable finding, actually. It's still debated whether this is true, and it has not been reproduced, but partly for the reason that nobody has access to such a big database that they have. So I'm not sure that anyone would be easily able to reproduce this study, but nonetheless, this is the outcome they find. And once again, they demonstrate that in those same patients, those who have delirium versus those that do not, the intraoperative alpha band is considerably lower. And so their whole idea here as well, we've decided that patients who have burst suppression have a low intraoperative alpha, and burst suppression is a mediator of delirium. So maybe we can do something about that by targeting this abnormality before they get burst suppression and try to prevent the appearance of burst suppression under general anesthesia. So what we've said here basically is that if you have an EEG that looks like this versus an EEG that looks like this, you are considerably lower likelihood of having intraoperative burst suppression and maybe to have postoperative delirium. And this is the association. If your alpha power is falling off, this is in decibels, so this is logarithmic. But if your alpha power starts to tail off, you get this really steep increase in your incidence of burst suppression, and also can transpose the risk of delirium. What's cool about this too is that it takes you away from presumptions about the patient's risk. So for example, here's a patient who's 35 years old and normal. Under anesthesia, they have this very strong alpha band here. Here's an old patient with a very low intraoperative alpha band. This we see often. Patients who are old generally have a low alpha amplitude, but you get some patients who are young, and you get stratification between a young patient with a good brain and a young patient with a bad brain. And if you take this group of patients and you stratify them based on their alpha band, you again can predict intraoperative burst suppression, and you can predict robustly the incidence of postoperative delirium. So this is harkening back to those 1950s days. This is giving us more information than we have at our availability by simply looking at the chart and examining the patient and guessing about their risk. So what about the patients who have not yet had an anesthetic? Because it's fine to say, okay, well, I'll give you an anesthetic and then we'll see, right? But that's kind of too late, right, at that point. You've decided to have surgery. You're not giving an anesthetic as a test. You're giving an anesthetic to facilitate surgery. So it's too late. So we have now, this is a paper from last year. We have now a lot of interest in saying, can we look at EEG preoperatively to see if we can make that same prediction? Because it's not just under anesthesia that we have alpha frequency activity. The alpha frequency is one of those things we see in the normal EEG at rest. I had an example before. I'll show it to you. Let's way back a few slides here. This is all alpha frequency. This is what's called the posterior dominant rhythm. It's what we see in the back of the head with eyes closed in an awake patient. And in fact, this is also to a degree variable. We see a lower alpha amplitude in the back of the head in an awake patient, in old people, in patients with delirium, partly because they're inattentive, but partly because anyway, they have a low alpha amplitude. And we see this in patients with evolving cognitive dysfunction, like Alzheimer's disease, for example, cortical dementias. So Christian Gay, who's a Montrealer actually, but has done most of his training in the States, went about looking to see if we could discriminate the same difference in patients preoperatively. And so the reason we have eyes open and eyes closed is because normally that EEG finding goes away when you open your eyes. It's suppressed by eye opening. And so he wanted to say, well, if you have a patient with eyes closed and eyes open, what does their EEG amplitude look like in the alpha band at the back of their head? And so he was able to distinguish in two groups: patients who had delirium, patients who do not have delirium. This is not cardiac surgical patients. These are general neurosurgical non-cardiac patients. And what he found is that in the group of delirious patients postoperatively, their preoperative EEG showed a lower alpha power during eyes closed compared to the group that did not have delirium. And here we see the expected finding that in the patients who have normal EEG with a big alpha band on eyes closed, when they open their eyes, it's suppressed. That's normal. This is just a proof of principle. But this is the finding that if you have delirium, you're much more likely to have an abnormal alpha rhythm preoperatively. So we now have a biomarker that's present intraoperatively. That same biomarker is present preoperatively. And so you have now some convergent lines of evidence that suggest that the alpha band might be a good or a better marker of intraoperative alpha power, intraoperative burst suppression, and postoperative delirium. So the natural question is, what can you do about that? So this is a trial protocol. This has not been published yet, but essentially we're looking now, and there are currently three trials actually, looking to see if you can change your anesthetic strategy somewhat to modulate the frontal alpha during the anesthetic maintenance phase to affect a change on burst suppression and ultimately affect a change on postoperative delirium. So that's an open question. And in the next 2 years, I think we should have results from this study and one other. So to come to some sort of general conclusion, EEG has a very rich history in cardiac anesthesia. Initially, it was for anesthetic drug monitoring, but it eventually took on a role as a tool for patient safety. And I think from the way they describe in the paper, and they're quite, these 1950 papers are long and wordy, right? The way they describe things, it became this kind of indispensable tool of their institutions to help make the administration of an anesthetic and administration of cardiopulmonary bypass safe at a time when it was clearly unsafe with high morbidity and mortality. So it's neat to see EEG used in that way. And I think EEG is undergoing a renaissance now where it's once again being used both as an anesthetic monitor, but also more and more as a tool to predict bad outcomes in patients who undergo anesthetics and undergo cardiac surgery. So look out in the next 5 to 7 years for some interesting literature looking at preoperative and intraoperative EEG to predict outcomes in your patients. And one day I hope to see a day when we order EEG as a part of our preoperative investigation for patients who have cardiac surgery. Thank you very much. Please ask me your questions. You can ask questions about anything, things I've spoken about or not.
Bryan, thanks very much for talking to us.
Well, I think we'll give you a microphone. Hold on. Otherwise, the kids on Zoom won't hear your question.
Just wanted to say thank you very much for the talk. It was fantastic. Look at the history of EEG and anesthesia. Obviously, you know, I have an interest in this stuff as well. A comment about the processed EEG monitor. Certainly, I think the real value has been democratizing depth of anesthesia and this EEG signals for the average anesthetist. I think that's why it becomes a ubiquitous tool. Do you think that part of the downfall in using it as depth of anesthesia monitor is that it is a little bit imprecise correlating those EEG numbers to what's happening with the EEG itself? And do you think that burst suppression, either as a Boolean operator on or off, the burst suppression is another signal maybe that in the future could help, you know, the average anesthetist recognize when anesthesia is excessively deep as the marker maybe for something that we can do about patients neurological symptoms? So that's question number one. Question number two is about hypothermia. Because it's not uncommon, particularly with a lot of aortic arch surgery and stuff here at the Heart Institute. And I'm often unsure what to do when the EEG changes during hypothermia in relation to both my anesthetic and analgesic management. You know, the goal of hypothermia is to reduce cellular processing, decrease metabolic demands of the brain. But the anesthetic does some of that too, particularly with cell-to-cell signaling. So what do you do with anesthesia? Do you give more of it as you're cooling? Do you actually give less of it as you're cooling? As the EEG continues to slow, as you get electric activity in the brain, do you have any feelings or thoughts on that? Because I've asked a lot of clever people and I don't have any clever answers as of yet.
So I'll preface this with a caveat. So I'm not a cardiac anesthetist, of course. The only on-pump cases I do are with deep hypothermic circulatory arrest for pica aneurysms, where we're going to actually exclude circulation and then do a pica aneurysm repair. So I do about 3 to 5 of those a year. So I do a small number of the cases that you're describing, but I do have some experience in that area. So maybe I'll start with your second question because it's the easier one to answer in a sense. So the literature in this area was rich in the 1980s. Mike Felder and his friends at Mayo were doing experiments on this very thing to tease out essentially what components of the cellular metabolics, of the brain metabolics, are addressed by anesthetics and addressed by hypothermia. And what they found quite conclusively, of course, is that as the temperature drops, especially 10 degrees below normal, so by the time you're at 27 degrees, you essentially have no more electrical activity at all. And so the only thing that's left is cellular function, and your anesthetics do nothing for that. They only address the energetic requirements for cellular synaptic activity. For the cellular metabolics, production of proteins, DNA repair, etc., none of that is affected at all by anesthetics. And so all of the heavy lifting of that cerebral protection will be done by hypothermia. So if you have isoelectricity in your EEG, there is no more value in adding additional anesthetic drugs. If you have burst suppression, then we can debate whether there's value in additionally getting that further. By the time you're anesthetized, you've already dropped down about 40% from your basal CMRO2 to something lower. The transition from burst suppression to isoelectricity is only associated with about 10%. So I guess the question is, if you have isoelectricity, change nothing. You don't necessarily need to decrease. It's not harmful at that point, but you certainly don't need to increase. If you have burst suppression, then I guess you could, if you want to eke out that last 10%, it would potentially be worthwhile to increase your anesthetic administration. But I don't know that we have, in fact, we do not have any outcome-based evidence to suggest that matters for cerebral protection, sadly. For me, it's a little different because we also isolate the basilar when I do my cases, so I can't infer much about this for me. But if I see residual cerebral activity, I do increase my GABAergic drug to get isoelectricity. So if that's not achieved through cooling, then I will make up the difference with drug, but I would also advocate for slightly colder. Like occasionally we'll cool to maybe 32 degrees, and sometimes we'll go colder if the patient can tolerate it, and if we don't think the repair will be too long, then we'll do that. The first question for vulgarizing EEG. Democratizing, yeah, I suppose. So first of all, we have better devices now because we have transitioned from index-based to spectral-based assessments of EEG for the most part. And I think that has done a lot to make the tool more reliable and to make people feel more willing and interested to learn how it all works and find these discrete event-related potentials that will predict intraoperative behaviors and prevent adverse events like awareness, but also burst suppression and cognitive adverse events after. So I guess the answer to your question is, how do I answer this? The answer is long. The answer essentially is that we need to, I hate this, education, okay? Education is the answer to all these things. The tool is only as good as your ability to interpret the findings. And so that involves your understanding of how this works, understanding of noise sources and artifacts, your understanding of expected EEG. In other words, what should the EEG look like based on their preoperative EEG, their induction-based EEG, their EEG during maintenance, then their EEG on bypass, for example. There's all these stages where you can make inferences about what the EEG should look like, but it's only based on your understanding of what it should look like that you can target something. And that's a problem, right? Because that comes down to sort of knowledge, and that knowledge, as you can see, is evolving quickly. So there will always be a fundamental limitation because the EEG is an epiphenomenon. If I give you a small amount of midazolam and it makes you sleep, the EEG will look like sleep. It will not look like midazolam. So do you see the problem? So if I then tap you on the shoulder enough and you wake up, you'll wake up like normal. But that doesn't mean that the midazolam didn't have an effect. It also doesn't mean that the EEG should look like midazolam. But if I give you enough midazolam, eventually I will start to see the characteristic signature of midazolam, and that will not be sleep. And so we have this epiphenomenon where it depends on the brain state, but the brain state is driven by the drug that we give you to a degree. If we give you a tremendous amount of that drug, then we can get a different brain state. So that's another level of three-way complexity that makes the interpretations really, really challenging. So education, I guess, is the answer. I don't know. Yeah. Does that make sense? We'll talk after though, because it's a big issue, and it's something we're addressing at the level of the European Society for Anesthesiology. I'm part of a group that is developing a curriculum for EEG that will be standardized amongst all the European anesthesia residency programs. And that's a big thing, is how do you support that teaching in a way that's standardized when it's so heterogeneous? So it's a big, you asked a small question, but it's a big question actually, yeah.
Bryan, thank you for a wonderful presentation. My question, you've already partially answered my question, but it has to do specifically with, or more specifically with burst suppression intraoperatively relative to post-op delirium. I presume that all these studies that you have presented us were done in response to a quote-unquote standard anesthetic. And my question that I always have when I look at these EEGs intraoperatively is it the chicken or is it the egg? If I give enough anesthetic to anybody in this room, I can flatten their EEGs. Yeah. That doesn't necessarily mean that they're at high risk or low risk. There's other variables. So how do you sort these things out? I see burst suppression in the OR. Is it because the patient has less quote unquote brain reserve in response to my standard anesthetic? Is that a predictive sign at all? Or is it just that, you know, maybe I give more than I intended to and I just caused brain suppression and I'm the cause of the issue, and that has no predictive value? Thank you.
Yeah, no, that is the question, right? Because yeah, so for everyone else who's not in anesthesia, you can produce burst suppression in every brain at some dose of a GABAergic drug. It's possible. It's hard in children, but you can get there. In every adult, we not just we do produce burst suppression in almost everyone to a small degree, but it doesn't have that robust signal of harm in everyone. So it's the fact that at a very low anesthetic administration, they are so apt to produce burst suppression that is the marker of the cellular dysfunction at the seat of their cognitive issues. I've actually done a pretty good job of trying to include papers that only do that only have a standardized anesthetic that's reasonable. Sometimes you read the protocol and you're like, that's ridiculous. Like 140 of propofol for 6 hours, a ridiculous anesthetic, right? So I tried to include papers that actually only have reasonable anesthetics. But it's more, provided your typical anesthetic is reasonable, which knowing you, I know that to be true, then you see in your hands the breakdown of patients who are uniquely susceptible to burst suppression and those who are not, those who are robust to GABAergic drugs. So we still don't have a good way of distinguishing those who are just receiving maybe a slight overdose of drug and it's actually not declarative of a problem, versus those who will be at a durable and reproducible risk of postoperative delirium.
I guess a quick follow-up question would be, is there any harm in overdosing somebody who doesn't have a predisposition to that?
There doesn't appear to be. We do this in children all the time. There was a nice paper that was just published a year ago that looked at children undergoing MRI under anesthesia, which we do typically with propofol infusions in most large centers in the country, or in the world rather, but without EEG for reasons of signal artifact. You can't put an EEG machine in MRI for obvious reasons. We can, but not the ones we use anyway. They're ferromagnetic. So anyway, but there was a group that did. They got a proper EEG machine that is MRI compatible, and they prospectively audited, blinded the anesthesiologist, just said, you do your normal thing. And we were suppressed like 60% of these children and they all wake up fine and they go on to lead healthy lives, and there's no association of that with any ADHD or any neurocognitive outcomes at all. So burst suppression alone is not sufficient. You need to be susceptible to burst suppression. That's the phenotype. And actually this comes down to the validity of that triple low, the observation that despite a low anesthetic administration, you still get some really low BIS, or in other words, lots of burst suppression. That's the pathology. But we don't know how to figure out who that person is versus somebody who's just receiving an inappropriate dose of anesthetic. And if you just tail it back, you should be fine. So hopefully that study that's looking to optimize the alpha amplitude, which will also target burst suppression as a second metric, hopefully we can then say, well, if you intervene on it, then you modulate the risk or not. We'll see.
Thanks very much for coming. Very interesting presentation.
Thank you.
I'm not an anesthesiologist. I do wonder, you did talk about the difficulty with teaching and training and learning.
Yep.
And I would have to think that somebody's looking at the use of AI to simplify this and allow more people to be using it properly and appropriately. Can you comment on that?
Yeah, absolutely. So in fact, this is a simple mathematical problem, right? Taking the EEG and in real time assessing the EEG for the alpha power and tracking that over time is actually a simple mathematical problem. So it has been subject to machine learning algorithms since about probably 12 to 15 years ago. And there have been some very interesting little applets, which are not on any device you can buy, but if you have a computer in the operating room, you can use this stuff. But the short answer is yes, it has been the subject to AI with great and interesting value. The problem is that the signal to noise ratio is very, very, very poor. And in the operating room, it's particularly bad because we use electrical surgical instruments that have electromagnetic interference that is orders of magnitude higher in amplitude than the EEG. So getting an artifact-free period that will be suitable for applying machine learning continuously, because it needs to be something live, right? It turns out to be a very difficult problem. If you want to do that manually, where you feed in an artifact-free segment that you have scrutinized yourself, then it's quite easy. But if you want a machine to actually decide this is an artifact-free segment, it's actually a difficult problem. And it turns out that that seems to be the most difficult element of the question you're asking. It's just, can a machine determine what is an artifact-free period of EEG that makes sense to use as its interpreting database? To provide it a database of already filtered data is quite easy, and that's the training data set for that machine learning algorithm. But to then say, okay, find me a piece of data that resembles that data set is actually a really difficult challenge. So we will see. There are a few groups in Germany and one group in the US that are doing this in a big way, and they're publishing stuff at a relatively fast clip. So I think that probably in the next 5 years we'll have something that will appear in the next iteration of one of these devices we have, and I have it on kind of under the table advice, I guess, from someone that will be a feature of the next SedLine device, which is a Masimo device that we have here, right? Yeah. So in the next version of that, there will be something like that. That will be a predictive tool to say, well, this patient based on this phenotype appears to have the following risk of delirium postoperatively. It'll spit out a probability for you. So it's exciting.
Glezerson, thank you so much for coming. We really appreciate your time.
Cool. I'm so late.